Good afternoon, everybody, and welcome to the Wage Spring Conference 2021. Really good that so many of you have been able to join us this afternoon. So my name's Hayley Hurd and I'm the president of Wage. I took over in December last year. Just like to say thank you very much for joining us. I hope you're all staying well and safe at this difficult time. Just need to start with an apology for not having my camera on, but the bandwidth doesn't seem to like it this afternoon, so I'm hoping that the audio will last. It's a real shame that we're not able to meet in person today, but we are still living in these really strange times. But thankfully, we do have things like this that enable us to meet virtually. So we know that the last 12 or 14 months or so have probably been the most difficult ever for all of you working in the NHS. We continue to face challenges on a daily basis. So we thought taking a whole day out for a conference this year might be a bit difficult. So we planned 3 short sessions and hope that this is going to work for you. I'm quite impressed just how many people have registered for the few days. So hopefully it's going to be well received. We've certainly got some really good speakers lined up for the next 3 days, and we're really grateful that so many people have given up their time to come and talk to us. And I'm hoping that you'll find them all really interesting. So the sessions are pre-recorded, so you can go back and look over them again. For those of you that are not able to make it, they will be able to look up the sessions. But speakers are also going to join us for the live discussion sessions as well a bit later on, so that should be helpful. So this afternoon session we're going to be focusing on COVID, the impact of COVID and recovery, which is going to include training and sustainability. And then tomorrow we'll be looking at new developments, and then on Wednesday there'll be more of a focus on quality and service improvement. So we are using a different platform this time based on feedback that we had from the last conference. So we're using a platform called AirMeet. It'd be really good if you could let us know how you find it. We're hoping that you're not going to have any difficulties joining us, but we've certainly had some good feedback about this platform when it's been used elsewhere. I just want to send a really big thank you to Adam and Arwin, who have enabled us to try a new platform. It's obviously the first time we've used it and could be a little bit daunting, but they've been really helpful, and I'm hoping that it's going to work well. So there is a bar in the side which is similar to the Teams, which you'll be familiar with. If you wouldn't mind using the question icon to pose any questions that you want a specific answer to, and we'll make sure those questions are then included in the discussion sessions. There will be an opportunity to put your hand up, but obviously depending on the number of questions we get, if it's written in under that icon, we'll be able to get back to you with an answer. So the chat bar is fine for just general comments, but if you could use the question bar for things you want an answer to, that would be really helpful. So I'd also just like to thank John for stepping in at last minute this afternoon to help me chair this session. So really grateful for John for his support as ever. And John, as you know, is Vice President of Wage, and he's very kindly agreed to help me chair this afternoon's session. So I'll hand over to John now, and we'll have a chance to speak again a little bit later. Thank you, John.
Great, thanks a lot, Hayley. Hi, everybody. Hayley was apologising for having her camera off. I ought to apologise for having my camera on. I didn't realise I was going to be chairing, otherwise I might have brushed my hair and had a shave this morning. It's my great pleasure to chair this first session, and as Hayley has said, this last year has been probably unlike anything that we've experienced during our professional and personal lives. And we thought it's important to acknowledge this. So the first few talks that we've got today are focusing on the impact of the COVID pandemic on aspects of our GI services, and also to hear about recovery plan in Wales, in the NHS in Wales. So our first speaker will be known very much to everybody, I'm sure, on this call, and that's my friend and colleague, Dr. Andy Yeoman. So Andy is a consultant hepatologist in Iron Bevan in the Gwent Liver Unit, where he was appointed in 2010. Since 2016, Andy has been the clinical lead for the Welsh Liver Plan, and he's a member of the Lancet Commission into Liver Disease in the UK. He's also been a member of a couple of BSG guideline writing groups looking at abnormal liver function tests and autoimmune hepatitis. His clinical interests are in the preventative care and early detection of liver disease and its complications, and he's also continued to have a major interest in autoimmune liver disease. And he was awarded an MD for work he undertook in this subject whilst working in King's College Liver Unit. So Andy's talk, which is the first one in this session, is on liver, transforming services and new models of working.
I'd like to thank the WAGE organisers for inviting me to speak to you today on the impact of COVID and transforming services and new models of working in Wales. The first thing to do is to really set the scene and to identify the scale of the challenge in front of us in relation to liver disease care in Wales. And this is data from the Welsh Liver Registry, which looks at all liver disease registrations from 1999 to 2019. And when we do this, it's very clearly evident that the number of liver disease registrations year on year has increased, and it's now 3.5-fold higher than it was 20 years ago. Interestingly, alcohol has not actually significantly increased. In fact, it may have actually slightly decreased as the number of new liver disease registrants per year, but fatty liver disease has increased almost 10-fold. And this really explains the large-scale rise we've seen in liver disease diagnoses in the last 20 years. Now, you can argue that this is just about increased recognition, but that's actually not the case. So if we look at the major adverse consequences of chronic liver disease, namely cirrhosis, portal hypertension, decompensation, and liver cancer, we've seen that these have all increased in the last 20 years. So we've seen almost a doubling of the number of cases of cirrhosis. We've seen a 2.5-fold increase in portal hypertension and a similar increase in episodes of decompensation. And really quite a significant increase in hepatocellular cancer as well. The drop off in the last year is because of an incomplete year of recording. So that's the background prior to the pandemic. What about the impact of COVID itself? And I think there's a number of different specific impacts that COVID has had on that affect our ability to provide high quality liver care in Wales. The first is really the redeployment of staff in the early first wave. That was both consultant and specialist nursing staff were redeployed to general medical rotas or to ward-based rotas to provide that emergency care to deal with the first surge. There was also the initial cessation of all elective activity, such that we did very few outpatient clinics across the whole of Wales during that first wave. And even now, as we're coming out of a second wave, there are ongoing restrictions in the physical environment such that we can't see the same number of patients as we'd normally see because of social distancing rules. Add on top of this the levels of patient anxiety about coming to hospital for face-to-face appointments for clinical review or for scans to monitor their liver condition, and a reduction in GP attendance in patients with existing liver disease or with the possibility of a new diagnosis of liver disease. And we really stored up a lot of problems as a result of the pandemic. This data looks at the gastroenterology referrals to ABUHB through 2019 and 2020. And you can see that prior to the pandemic, we were averaging around 1,200 referrals a month. And this dropped down to 369 in April in that first surge wave of COVID. And though it gradually increased up and we haven't seen a big drop off towards the second wave, actually we're still about 80% of where we would normally be. So we're still not seeing exactly how many referrals we would do. And although this is not specific to hepatology, this is for the whole of gastroenterology, a similar picture has been seen in liver services as well. And the worry is that actually we're storing up more severe cases and we're seeing more severe first presentations. And although we don't have good quality data on that yet, I think that will probably come as anecdotally we've all seen late presentations of hepatobiliary disease. So how do we incorporate this into how we transform our liver services in Wales? And I think the first thing to say is that transforming the services was really the major part of the Liver Disease Implementation Group's work that commenced in 2015. So this is work that's been ongoing within Wales even prior to COVID, but COVID's clearly been another major driver of the need to transform what we do. More of the same is just not going to cut it from here on in. So is this an opportunity or a threat? Well, I'd certainly prefer to see it as the former rather than the latter, but it's actually quite a complicated picture. And obviously some health boards in Wales are starting from different positions of strength, and that has to be borne into mind when we come to any sort of determination of what the right thing to do is. So where do we start? So this has really come off back of work that I heard Sally Lewis, who's the national lead for values-based healthcare, talk about at a Welsh Government meeting a few months back about how we recover services in the post-COVID era. And it sort of encompassed 5 major domains, and they translate very nicely to the major remits, or some of the major remits within the National Liver Plan. So the first thing to say around this is that obviously it goes without saying that the patient needs to be the heart of everything we do here, and that we need to find better ways to diagnose and to manage people without admitting them to hospital wherever possible. But around that, there are 5 major domains that we need to adhere to or pay attention to. There's prevention, there's primary care and early detection of liver disease and the management of ongoing chronic liver conditions in primary care. There's inpatient hepatology and how that links in with intermediate care and then into primary care. And there's always the chronic disease care element as well. And all of these major domains interplay with one another. And there are a number of different drivers and enablers for high quality care in each of these themes or domains. So if we look at theme 1, which is prevention, the major ones in relation to liver disease are the commonest causes of liver disease within Wales. And that's alcohol misuse, obesity, and bloodborne viruses. In terms of alcohol misuse, alcohol care teams in Wales are still some way off being optimal. There's still no 7-day service anywhere in Wales. And although we use a lot of pump prime money from the LDIG, this has not been taken over by health boards as this money has run out. And this has been particularly disappointing given the ongoing demand we see in relation to alcohol misuse and admissions to hospital. As an LDIG, and I hold my hand up as well, I've failed to convince health boards to make alcohol care teams a priority. And I've even met with the All Wales Medical Directors Group, and it still struggles to get the message home of how important these services are. Now, maybe this sort of data will help convince them, but they've already been presented with multiple episodes of the benefits of alcohol care teams, but this is alcohol-related deaths in Wales over the last 7 or 8 years. And you can see that broadly speaking, there's been an increase in alcohol-related deaths with a slight drop off in 2019, but 2020 saw the highest recorded alcohol-related deaths in Wales since records began. You'll see that alcohol-related deaths represent about 80%, alcohol-related liver disease deaths make up 80% of all alcohol-related deaths, and these are also at a record high. So clearly, lockdown, the impacts of COVID have had significant impacts of alcohol consumption, and that will have offset any gains from minimum unit pricing, for example. And we clearly still have a high burden of alcohol misuse in Wales, leading to significant adverse consequences. If we look at weight management as a preventive tool for prevention of fatty liver disease and progression of liver disease, then we know across Wales there's a significant variation in access to Tier 3 weight management services. And this is a problem, particularly because patients don't get that sort of high quality weight management intervention, but it also acts as a de facto barrier to Tier 4 weight management services, namely bariatric surgery. And Morriston remains the only centre in Wales providing this, and there's nowhere near enough procedures being done across Wales. In fact, it's the lowest across the whole of the UK, which is lower than in most parts of Europe. In terms of the second theme, which I look at the early detection of disease, I think we've made some good headway with this, and this has been a major focus for the LDIG over the last few years. And we've developed a national liver blood test pathway, which has been delayed, ironically, due to COVID and due to the fact that NWIS, we need to do some of the upgrades on the LIMS system, the laboratory management system for Wales, has been serially delayed, but we're hoping that this will be launched later in the summer. We've also talked about a FibroScan first strategy, so directing patients, where appropriate, directly to FibroScan rather than to a hospital appointment, and that can both speed up the RTT as well as making a liver disease diagnosis and advanced fibrosis and cirrhosis. The other important piece around the early detection of liver disease is to support primary care, to raise the knowledge and awareness of liver disease and how to detect it in a primary care setting and provide a supporting system around that. So in that regard, this is the algorithm for the All Wales abnormal liver blood test pathway, and it really deconstructs abnormal liver blood tests into 3 major themes. Why are liver tests abnormal? What are the red flags for either admission or urgent referral? Thinking about why they're abnormal, the patterns of liver test disturbances, the critical importance of fibrosis risk assessment, which will be automated on the second abnormal ALT in the All Wales pathway, and then onto either referral to hepatology or the management in primary care. Now, each of the QR codes around this algorithm, when clicked on, or when scanned, will take the user into a short video explaining a little bit more about that section. And so the plan will be that each GP practice will get this sent electronically to them, as well as on A3 posters. The FibroScan First strategy is really an approach to deliver increased FibroScan capacity by using Band 3 healthcare support workers. They will generate a report which will be sent to clinicians for review and determination whether the patient needs to be seen in a liver clinic by either a specialist nurse or a consultant, and feedback provided, including recommendations around weight management or alcohol cessation, for example. And the key aims of this sort of strategy are to increase the FibroScan capacity across Wales to support the early detection of liver disease and the increased recognition of cirrhosis as identified in the Gwent pilot, where we've increased the rate of cirrhosis diagnosis by between 75 and 80% over the last 4 years. It also allows us to move these services out from the hospital care setting more into community settings. GP clusters, for example, is one of the opportunities to move this sort of service out because FibroScan is very portable. We can reduce waiting times as well as shorten the whole RTT pathway. So we found that in Gwent, since we've employed a Band 3 nurse, we got the waiting times down from about 6 months to about 6 weeks. And nobody waits more than 8 weeks now for a FibroScan. And also about 45% of patients with an abnormal liver blood test being directed straight to the FibroScan don't need to be seen in a primary care clinic, in a secondary care clinic rather, and can be managed in primary care. The HCA will also ensure that the liver screen is completed where those bits are absent and can provide brief advice and signposting to weight management or alcohol cessation services. And also this can free up capacity within the other aspects of the hepatology service to support disease monitoring. And I think we need to use FibroScan far more smartly in terms of monitoring for disease, working out who should have variceal surveillance and so on. In terms of the primary care education support, I've already referenced the pathway that will be sent out to GPs, but that's part of a broader implementation strategy that the ICST who've delivered the program for us or worked with us on the program will oversee. You'll be familiar with their work probably from the COVID guidance, but what we produce is a series of short TV clips that will signpost people to the different aspects of the pathway. There'll be a question and answer session that they can complete before and after looking at all these. And when all modules are looked at, the GPs will receive a professional development certification for their accreditation and revalidation. This process will also allow for tracking of who's engaging with this process, and we will aim to link that to the areas which have a good uptake with the pathway, and whether that's leading to increased cirrhosis detection rates through the data we're recording as part of the National Liver Registry. Theme 3 is around inpatient hepatology care, and there's a number of different and quite simple things that can be done to make a real difference. And the first two obvious ones are to embed care bundles. So Basel and the BSG have co-produced a decompensated liver disease care bundle, which is for use for non-specialists in the first 24 hours of admission. So that's targeted particularly at ED and MAUs. And similarly, they've now produced a discharge bundle, which helps engage better with primary care and gives primary care doctors the key information and the key actions to follow if a patient deteriorates after a recent admission. We come back to alcohol care teams and the need to really view these as having both a treatment and a preventative role. They remain small and fragmented across Wales, and we need to continue to push to use this data on rising alcohol-related deaths to push for additional resource within these teams. The final aspect for high-quality inpatient care is the need for liver rehabilitation, incorporating intensive dietetic input to manage the sarcopenia, increase the calorific intake as well as the protein intake for these patients. But that has to be allied to a strategy of physiotherapy and getting people moving again. And this is going to be vitally important to improve the quality of life of people with cirrhosis and decompensation, and also get more people through to transplantation where that's appropriate. Theme 4 is around intermediary care, and some people call this ambulatory care, but I've started to move away from that terminology because that doesn't truly encompass the severity of, or certainly severity of illness of some of these patients that we see in these sorts of settings. It does, however, encompass patients for day case paracentesis, where you can prevent a hospital stay of 3 or 4 days by doing this on a day case basis. Early post-discharge reviews for patients with acute jaundice, drug-induced liver injury, autoimmune hepatitis, and also for patients who might need diuretic management or tweaking as a result of an admission with ascites. GP advice lines can both help prevent admission, but also prevent onward referral, and also increases the educational knowledge of liver disease in primary care and builds links with practitioners in the community. HOP clinics are a really important part of that sort of bridging care, whereby we can see patients rapidly with new onset jaundice or new onset of apparent decompensation to try and avoid admission where possible. And finally, we need to have strong engagement with palliative care and community frailty services for those patients who are nearing end of life, which is a common scenario in patients with decompensation. The final theme is around chronic disease care, and I think there's a number of things again that we can do to try and transform our services. And one of the really important ones is cohorting. And this is important work that will come out of the Wales Liver Registry. So we're shortly going to be able to share with each health board their profile for liver disease in their area, which is the number of patients with cirrhosis, with decompensation codes, autoimmune hepatitis, hepatitis B, hepatitis C, so that you can start to really design what our services need to look like. And that will also allow you to determine which patients are best managed by specialist nurses if certain areas find consultant recruitment difficult. Disease monitoring around HCC surveillance, well, unless you know how many people with cirrhosis you're looking after would be eligible for that, is challenging to really plan for. And variceal surveillance is another similar thing. We can actually prevent the number of endoscopies we do by using FibroScan and the Baveno criteria to filter out which patients are at risk of having clinically significant varices. So I think we need to move towards this idea of having complex clinics. Now, obviously, this will be variable depending on the size of the health board, but actually there will be enough cirrhosis in each health board to warrant setting up one of those at whatever interval is deemed appropriate based on the numbers. And this would be best served by having a consultant and a trainee present for their education and professional development. In Gwent, the model is that we have a consultant and a trainee present, often more than one consultant on a monthly clinic, at which we have the CNS present who will undertake a critical flicker test to look for hepatic encephalopathy. We'll do the liver frailty index, which is a validated measure of severity of sarcopenia and its functional effects. There's a dietitian present to manage the deleterious effects of sarcopenia. Alcohol liaison is also there to support patients with alcohol misuse disorders. And we've recently gained funding to have a clinical psychologist present at this clinic to support those with mental health needs and other anxiety-related issues related to possibly transplantation assessment, etc. So what are the vehicles for this sort of change? I think, well, we need to move to this principle of having sort of hepatology integrated care services that work not just in the hospital walls, but reach out into the community around prevention, around early detection of liver disease, around intermediate care and supporting the patient throughout the whole journey of their liver disease. We can smartly use IT and data, particularly around the liver registry stuff. We can also think about how we integrate our clinical workstations or our national clinical portals into providing us with the information we need to manage our patients properly in clinics. We've already started on national pathway development, and we should develop some national clinical standards. And there's always the IQLS process as well, which is important to drive this. And I'll be speaking more about that on Wednesday. So this is our hepatology integrated care system in Gwent. So we have the Grange University Hospital, which have inpatient care. We have an inpatient MDT weekly. We use Watchlist to identify where patients are on the system. We use liver care bundles, and the alcohol care team is built into this, as is the RAIL system, which is the Rapid Assessment Intervention in Liver Service, our intermediate care facility. That links into primary care, so we have the early detection pathway. We have GP advice line. We're developing cluster outreach alcohol clinics, hopefully this year. For outpatients, we've got the complex one-stop shop clinic I've mentioned. We started to think about pooling subspecialty clinics and cohorting patients. We have a rapid access CNS follow-up clinic, and we have the FibroScan service in the community. Our nurses are now also able to do home visits for those patients who are coming towards the end of life and very frail. The BVV service works very strongly in community settings and works on educating and engaging in primary community settings such as the mosques. Then we have linkages with services such as the Gwent Drug and Alcohol Service, hematology for patients with thrombocytopenia and splenomegaly, that's unexplained, to FibroScan those, dermatology for methotrexate monitoring, and diabetes, because these patients are at a high risk of fibrosis, whether they've got abnormal liver tests or not. IT and data, well, the World's Liver Registry, as I've said, will be hopefully used to really map out what is required from a workforce perspective, and the development of ongoing national service standards will, I think, be integral to the development of high quality liver services in the next few years. We'll be defining workforce requirements, and just a brief note on the use of telemedicine. We need to be cautious that we don't exacerbate existing inequalities, as many patients with liver disease do not have access to the technology required to use telemedicine. The national service standards are around pathway development, clinical metrics, and maybe national audits. But the key bit around this is PROMs as well. Collecting patient-reported outcome measures will be an important part for us to understand what truly matters to our patients, so we can redesign services around that. And that's a big gaping hole in our services as things stand at the moment, and a gap we certainly need to fill. I'll talk more about IQWILS on Wednesday, but this is just to say that this is a framework for service improvement, and all sites in Wales, or all health boards in Wales, are currently registered. And this is really to drive patient-centred care, and it uses a knowledge framework that shares best practice across the whole of the UK. We found, certainly in Gwent, that it enhances the managerial engagement with liver disease services, and it sets key metrics so you can benchmark yourselves against other services in the UK. So in summary and conclusion, I think COVID has merely exposed the fault lines in our systems and exacerbated the already long waits we often have within our liver services, and exposed the fact that we're short on workforce in some parts of our service. But it is a huge opportunity to start afresh, and I think organised services will stand to benefit from any new funding that comes out of COVID recovery plans. And there's an opportunity there to influence future delivery, but we have to take into consideration the fact that there's significant workforce fatigue, and that needs to be sensitively addressed when we talk about developing things anew. So I'd be happy to take any further questions.
Great. That's a fantastic talk. Thank you, Andy, very much. In terms of questions, as Hayley said at the beginning of the session, there's a little tab that you can click onto. It's on the top right of my screen. There's a chat bar, but there's also a separate question bar. So if you've got a question that you'd like to ask Andy, or indeed any of our speakers from the session today, then please put them in the question section, and we'll take them in the discussion at the end of the three talks. Okay, so just click anything in terms of questions onto the system there, and we'll pick them up at the end. So thanks very much, Andy. Our second talk is a double act, and actually I think on the programme it's got Gareth then Hayley, but actually the talks are the other way around. So Hayley is going to talk first, and we're looking at endoscopy, demand, capacity and recovery. Hayley, as you know, is our WAGE president, and for those who don't know, I'm sure everybody does know her, but she's the programme lead for the National Endoscopy Programme, and was previously head of programme for the bowel cancer screening programme in Wales. Gareth may be less familiar to you, but Gareth will follow on after Hayley's done her talk. He's a deputy director at the NHS Delivery Unit. And I've got to know him because he chairs one of the National Endoscopy Programme work streams. He's the chair of the Demand and Capacity Group. And Gareth's an authority and has a lot of knowledge about raising awareness around issues to do with demand and capacity, and as I say, leads our group in the endoscopy programme. So I think Hayley's going to go first and then follow on by Gareth. Thank you.
And I'm the programme lead for the National Endoscopy Programme. And you're probably well aware that we've had challenges with the endoscopy service in Wales for many, many years. And they relate to waiting times, but also to the environment. We've had challenges staffing units and retaining staff, and also support from senior managers within the health service and the wider structures within Wales. And generally there seems to have been a lack of investment in endoscopy services for many, many years. And that was recognised by an inquiry that the Health, Social Care and Sports Committee undertook in November 2018. And they published their findings in this document in April 2019. And round about the same time, the National Endoscopy Programme was established to address the challenges identified in this report. And the aims of the National Endoscopy Programme are to balance demand and capacity, achieve JAG accreditation for all units in Wales, to enable optimisation of the bowel screening programme and implementation of the single cancer pathway. So we recognise that this is going to be a considerable challenge, but we have developed an action plan for how we can address all of these issues. And the action plan was published 6 months following the report from the Health, Social Care and Sports Committee, and in response to that inquiry. So this is our action plan, published initially in October 2019, but refreshed in September last year, and will be refreshed again in September this year. So this sets out all of the actions that we'll undertake, which will enable us to achieve the aims of the programme. And we've established 4 work streams within the programme. So clinical pathways, facilities and infrastructure, workforce training and development, and demand and capacity. And each of these work streams has a clinical and a managerial lead, and each have developed a working programme that will enable us to work towards achieving the aims collectively. So each of these work streams conducted a baseline review, and we presented the findings of the diagnostic phase of the programme and baseline review at a workshop in March 2020. So we just about squeezed this in before the pandemic stopped us. But at that point, we'd identified a 90 list a week deficit across Wales. And that was despite spending around £8 million a year on insourcing and other non-recurring activity. So only 5 out of our units were JAG accredited. There was considerable variation in pathways, and we had no nationally coordinated approach to training. We had got significant environmental challenges in some units, and most units had some IT challenges, and there were very few units that were able to upload their data to the National Endoscopy Database. So we recognised at this point that there was a significant challenge, and that we would need to do things very differently if we were to develop a sustainable endoscopy service for the future. So that was in March 2020. And straight after that workshop, the pandemic hit, and there was virtually no endoscopy carried out at all for 4 or 5 months. And then when we started up again, there are significant restrictions from the COVID-19 guidelines that we now have to follow. So as you're all well aware, that the situation has not improved. So in March this year, we not only had the historical backlogs of patients waiting for procedures, we now had new backlogs developing as a result of the pandemic and reduced capacity going forward because of the infection prevention control measures that we need to put in place. So many of our health boards are now reliant on insourcing just to keep our heads above water and to start tackling the backlogs. We still only have 5 units JAG accredited, and all of the environmental challenges that we identified 12 months previously still exist. So if anything, we are in a worse situation now than we were 12 months ago. And not only do we have to achieve the original aims of the National Endoscopy Programme, we now need to support health boards to recover from the pandemic as well. So as you can imagine, all local health boards, operational staff are working incredibly hard. They must be absolutely exhausted. So they have developed short-term plans which largely rely on insourcing in many health boards, but that being the only viable option at the moment to start addressing the backlog. And longer term plans are being developed in most health boards, and many of those rely on expansion of the existing units. But it seems quite clear that local plans are going to take some time to firm up and for funding to be allocated to them. And actually, the numbers that we've looked at, that Gareth will explain in a bit more detail shortly, don't actually add up to complete recovery. and it does seem to be that a national plan is needed to support health boards. So we've developed some guidelines from the National Endoscopy Programme to support health boards with recovery, but ultimately we do need to increase the capacity at a regional level, and we've worked up some plans that are being discussed within Welsh Government to develop new endoscopy units that can be accessed across health board boundaries. Now, these plans haven't yet been agreed, but they are being considered. But in the meantime, each of the work streams is working with the local health board teams to do what we can to support recovery and development of a sustainable endoscopy service. So the Clinical Pathways team had developed an audit tool to implement the new surveillance guidelines, and this is currently being implemented within health boards. And once that's been done, the risk stratification tool that this work stream developed can also be used so that we can be certain that patients waiting for surveillance procedures are only waiting if they really need a procedure, and those at the very highest risk could be offered a more timely procedure. We've developed a FIT framework to support health boards with a standardised approach to using the fecal immunochemical test within the symptomatic service, and recovery guidance and pathway mapping also being developed within this work stream. And the pathways will be aligned to the national optimised pathways. We're also looking at working with the informatics group to develop an end-to-end electronic pathway, and there are also plans to develop guidelines for implementing the polyposis guidelines. Facility and Infrastructure Group are one of their main aims really is to ensure health boards achieve JAG accreditation. So they've just conducted a round of virtual health board visits to discuss the action plans. We'd previously commissioned pre-JAG visits, so health boards now have a detailed action plan which needs to be followed in order to achieve accreditation. This workstream is also working to ensure that we can access results on the Welsh Clinical Portal. That's about to go live in one health board, but we're hoping that the others will follow fairly soon afterwards. And we're collaborating with shared service. Decontamination has been identified as a risk, and we're working with health board teams and shared services to mitigate that risk. We're also helping health boards identify solutions to airflow issues, which could potentially increase capacity. And we're also working with Digital Healthcare Wales, who used to be NWIS, to appoint a business analyst who can take forward our four main informatics aims within the programme. The Workforce Training and Development Group is in the process of developing an endoscopy training management group, which will provide the governance structure for a centralised training, centrally coordinated training programme for endoscopy in Wales. And this will sit within Health Education and Improvement Wales. So we have two cohorts of clinical endoscopists, one just in training, they've been in training about 12 months, and the second cohort just appointed and will begin their training shortly. We've also are developing a training programme for all groups of staff who work within endoscopy, and we have undertaken an initial exercise to look at what staff we currently have working in endoscopy and what the skill mix looks like. And we'll be using that information to develop the ideal skill mix so that we can support our health boards work towards that. And we've also established two task and finish groups, the first to look at developing a specialist bank for endoscopy, and the second to develop a recruitment and marketing campaign. And the fourth subgroup is demand and capacity. You will be hearing from Gareth Lee shortly, who's our managerial lead for this work stream, and he has much more data that I think you'll find interesting. But this work stream has developed a national demand and capacity planning tool, which has been used within health boards and has enabled us to identify the national demand and capacity gap using standardised definitions. And this work is being progressed to make sure that we're able to provide the level of detail that we need to report to the board, but also for health boards to use to manage their service. So I'll hand over to Gareth now, and he'll be able to share with you much more detail around the work of this work stream. Thank you.
So my name's Gareth Lee, and I'm the chair of the Demand and Capacity Work Stream for the National Endoscopy Programme here at the NHS Delivery Unit. So we collect capacity and demand data for the programme, and we do that on a regular basis. The presentation I've got for you today contains data from most health boards, but not all. We start by looking at the capacity and demand for each of the areas. The requests reflect the demand that comes into the service. The activity in graph 2 is the activity that is being done, and then we've got a comparator of the waiting lists in the bottom graph. As you can tell from the top graph then, requests dropped dramatically within the lockdown period. This graph shows that quite nicely, but started to recover later on. And activity reflected that, so no surprise there. And as a result, of course, waiting lists in the bottom graph there grew. So was that different for urgent suspected cancer cases? Well, the pattern certainly is the same. There was certainly a drop within the demand in this graph at the top, but the recovery seems to have got back to pre-COVID levels, according to the top graph. And activity reflects that as well. And as a result, in the bottom graph on the screen at the moment, you can see the waiting lists have started to get back to a normal sort of level. The picture, therefore, for routines is very different. The recovery of routine cases coming back in as requests is taking a much slower trajectory into returning to previous levels. And of course, the ability to deliver the activity, given the restrictions that we have within units at the moment, is limiting the activity levels. And not surprisingly, for routine cases, the waiting lists show a sharp increase and are going up steadily. Looking at screening separately, you can see that the screening levels have started to come back up in terms of the requests to the levels they were before, and as a result, so is the activity. Is that a typical picture for all the health boards up and down Wales? No, there is variation within different health boards. There's different levels in different health boards, and it's reflected within the graphs here. And clearly, I wouldn't expect anybody to look at the individual graphs concerned here, but you can just see there is variation in terms of the recovery for those requests and that demand. And just to illustrate the point further, if you take the highest one, this is the top example where one health board has almost got back to the levels it was previously. The bottom one, or the lowest example, where clearly we're nowhere near that recovery level, so we expect requests to take some time to get back in that particular health board. And what's that done to the overall waiting lists? This graph doesn't contain screening or surveillance, but as you can see, not surprisingly, from the time when lockdown occurred, those waiting lists, as illustrated earlier, have gone up. Not all health boards were able to give us screening waiting list information, but those that did, I think you can see a clear pattern. So it's up, it comes down in the period towards the summer, and then starts to go up again for all health boards, all showing that pattern and that swoosh. But probably the most interesting part of the presentation is the capacity view. If you look at the graph at the top of this page, the grey line illustrates the capacity that we had in the system in Wales pre-COVID, and in the original work that we did back pre-March. None of the capacity is back at that level at this point, and that's illustrated by these columns here. But what's interesting about these columns is that they're broken into two sections. One is the blue part, which is your core capacity within health boards, and as you can see, it's almost at half kind of level from where you would hope it would be. And then it's topped up with non-recurrent capacity. So that'll be typically insourcing, outsourcing, or waiting list initiative capacity. So we really are trying to make up some of that capacity within organisations through these avenues. But there's a clear amount of non-recurrent capacity being utilised at the moment to try to keep the service going. And if you come away from the top graph and look at the individual ones below it, you start to see just to what extent that's true of different health boards, or at least the way that they reported to us anyway. You can see in some health boards, it's much bigger than others. In other words, they're heavily reliant now on the non-recurrent capacity to prop up the services to the levels such as they are. And when we're not even back at the grey level, which is pre-COVID levels yet, you can see the issue regarding capacity shortfall. And is there consistency around the number of lists that are available? The top graph tells you that there probably is, in as much as there's not a great reduction in the number of lists. So where's a reduction? It's in the bottom graph where you have a variation in the number of points. So you can see that the points are quite varied in the bottom graph between different health boards, and that's points per list. So some are up as high as 12, they're telling us, others still down as low as 6 and below. So quite a lot of capacity not in the system at the moment, and quite a lot of variation across health boards with regard to that capacity. So if we look at that demand, if we compare it to that capacity, and we try to project what would waiting lists look like going forward, you can see that the projected position without that additional capacity we talked about earlier, i.e. waitlist initiatives, insourcing, outsourcing, etc. If we were to project that up, we would see a very sharp incline in our waiting lists going forward and get into levels that are really quite significant. And we forward projected that to March 2022. And even if you put in those recurrent solutions, those insourcing, outsourcing and waiting list initiative capacity areas and build that in, it still shows a relatively sharp incline in terms of waiting list projections up to 2022. So even with those added, we still have a system which has high levels of waiting lists in them, and we're not projecting that to get much better soon. So that's it from me.
Great. Thank you very much indeed, Gareth. Thank you very much indeed, Hayley. It's very exciting being backstage here. There's all different people's names coming up in tiles next to me. So hi to everybody who's joined since the start of the meeting. Just to remind you, if you look on the top right-hand side of your screen, there is a chat function. But if you want to ask a question, then please just click into the question mark and put your question in there, and we'll pick them up in the discussion section at the end of these 3 talks. I think we be able to put hand up and verbal questions as well, but if you can type in any questions in there, be gratefully received. I can see Umakant is first in with doing a question earlier on, which we'll take later on, but please follow suit. I'm sure that talk that we've just had there will stimulate some interest. It certainly shows the challenges that we have in Wales ahead of us in terms of our endoscopy capacity and our demands. So the third of our talks today is given by Simon Dean. Simon is the current Deputy Chief Executive of NHS Wales, and he co-chairs the Executive Board of the National Endoscopy Programme. He's worked in the NHS for many years, started in 1983, and has had a number of important key leadership roles, which have continued since he moved to war. His roles, aside from his current ones, have included being Chief Executive Officer of Health Commission Wales. He's been a Director of Planning and Performance in Welsh Government, and has also been a former CEO of Velindre NHS Trust, and had 2 spells as Interim Chief Executive in Betsy Cadwallader. His talk is entitled The Wider Recovery Plan NHS Wales. Thank you, Simon.
Thank you for the opportunity to join you at your annual conference today. COVID-19 has had a devastating impact on society, the NHS, individual people and families. Who could have imagined 18 months ago that a global pandemic was about to emerge and affect the lives and well-being of so many people? I'd like to begin by expressing my thanks and admiration to you and all of your colleagues for your tireless work in very difficult circumstances. I know that it's been an incredibly tough time, both professionally and personally. Thank you. The response to the pandemic within the NHS was incredible. As the pandemic hit, I had just started in post as interim chief executive at BCU, and I witnessed at first hand the speed and creativity of the frontline response. I know that this was mirrored in every organisation across Wales. The focus on preparing for and treating COVID patients was intense, and we saw many examples of the rapid development of pathways, red and green zones, digital solutions, and much more. We also saw great concern for patients requiring other treatments and the very real worry about the harm that they might be suffering as a result of delays. There were impacts right across the healthcare services, including in endoscopy, as you all know all too well. At the end of March 2021, there were 18,291 people waiting for diagnostic endoscopy across Wales. This compares to 10,512 waiting at the end of the previous March, a rise of 74%. For those waiting in March 2021, 61% had been waiting for 8 weeks or more. In March the previous year, that was 17%. Similarly, in March 2021, there were 5,811 people waiting for 24 weeks or more, some 32% of all of those waiting. This compared with 2% the previous year. Activity has also suffered greatly, as you will be all too aware. Between April 2019 and March 2020, there were a total of 95,314 endoscopy procedures carried out across Wales. That's an average of 261 every day. In the first 6 months following the onset of the pandemic, between April 2020 and September 2020, there were 17,412 procedures carried out, an average of 95 each day. So a very significant impact on activity that you and your colleagues were able to carry out. Thankfully, we're seeing a rapid fall in the number of people contracting COVID-19, and the pressures for the pandemic appear to be easing. The vaccination program is a huge success, and we are seeing social distancing measures relaxed. We are moving back towards normality, or perhaps I should say a new normal, as none of us fully understand the long-term effects following the pandemic. Our document, COVID-19 Looking Forward, is very careful to say that it is not a recovery plan. The pandemic is still with us, and we will feel its impacts for some time to come. There remains the possibility of further waves as new variants emerge and as societal restrictions ease. In my mind, we are entering the next phase of the pandemic response, in which we need to continue direct actions against COVID-19 and take steps towards recovery. This will be a long haul and will be very demanding on all of us. We are very aware of the pressure which colleagues in the NHS have been under for well over a year, and we must take this into account as services recover and we seek to treat the backlog of patients waiting. There are many positives on which we can build. I mentioned earlier the changes we have seen over the last year or so, including the use of digital approaches. These will help recovery in some areas. We have seen streamlined pathways, more flexible working, and a strengthened team ethos. The commitment of colleagues has been extraordinary, with a can-do attitude very evident. Alongside the challenges of recovery come opportunities to plan for sustainability and equity, opportunities to look critically at how we organise services to protect them from immediate pressures, opportunities to accelerate innovation, and opportunities to strengthen the workforce. We all have a part to play in the recovery journey. From a Welsh Government perspective, our role is to work with the NHS to understand the scale of the challenge, to develop solutions including immediate actions, and to secure the resources you need to look after your patients. We have asked NHS organisations to set out their plans for this year, recognising the uncertainties which exist. The Minister has made available an initial sum of £100 million to support immediate recovery actions, which we are discussing with LHBs and trusts. The recovery of the NHS will, I'm sure, be a high priority for the incoming government, and we will continue to work with the NHS and social care to develop longer-term recovery plans. I know that despite the impacts of COVID-19, you will remain positive, energised, and focused on the opportunities to improve services to patients. The National Endoscopy Programme Board provides a vehicle through which we can maintain a high level of focus in endoscopy and work together to design sustainable recovery plans for these critical services. Thank you again for all that you are doing, and I look forward to working with you as we embark on the recovery journey.
Great, thank you very much, Simon. I think we need to take about just 30 seconds or so just to pull all the speakers together so that we can do a panel discussion session. So just bear with us, just literally 30 seconds or so, and then we'll be back to field questions. Great, I think we're back. I hope you can all see and hear us. I think the question facility was disabled for a short period of time, so please type in any questions that you want to ask in there. And also, Adam, who's doing a great job helping us to do the session, has mentioned there's a raised hand button above the attendees list on the top right. So if anybody wanted to ask a question, I think we can unmute your mic so you can speak, but we can't see you, but we can hear you. There's a couple of questions I think that people have put in there. I think they were mainly sort of discussion points, but if I can just bring them up, just set things off. I think the first, Andy, was for you from Umakant, and he's made a really good observation, which I think is an issue in probably way beyond gastroenterology. It's a big issue in our services, which clearly is a big aspect for patients with liver disease. And he says that we should push for this. What's your comment as in terms of your I-QUILS liver lead role for psychological help for patients?
I could completely agree. I mean, I think, psychological support for patients with liver disease and GI disorders has been absent, and I think there's huge discrepancy. So people with COPD have access to it, people with neurological disorders often have access to it. I think maybe if this is, if you look around the COVID recovery stuff, there'll be a lot of clinical psychology input into that, and that's really raised the profile of the role of clinical psychologists in healthcare. And I think it's something we just need to make sure that the voice for patients with GI and liver disease is heard, so that people understand when we're providing increased clinical psychology support across other aspects of the system, that there are other patients out there that would benefit from it. So I think, yeah, absolutely a role for Wage for banging the drum, raising the profile, and standing up for our patients to get access to that sort of support.
Brilliant. Thank you. Hayley, I wondered actually whether or not you might want to take the next couple of points which are linked together from FIRES around the number of patients on lists and COVID recovery, etc. Perhaps yourself and Gareth and Simon might be able to contribute towards that discussion. So FIRES has made a point that his service, like most of our services, is struggling because of the extra steps that have to take place, which we never had before, in terms of air exchange and all the flows through the unit, and how that's going to reduce our capacity to be able to get through as many patients as we used to do. Hayley, you'll just take that first, then maybe Gareth and Simon. Hayley, I think you're on mute, or you're... Whoops, I can't hear you, Hayley. Gareth, do you want to come in and... Gareth, we can't hear you either here. Simon, can I just check yours? Can you just see if we can hear you?
Yes, hopefully you can hear that.
I can hear you, Simon. Yeah, Gareth, can you try again? Whether it's a system glitch or whether there's something. No, we can't hear you, I don't think, here. Or Hayley at all. So perhaps Adam, if you can see if you can help us out anyway. I'm not sure whether you can help with Gareth and Hayley's mics. I can see Gareth's mouth moving, but I can't hear any words coming out. So there's obviously something happening in the system. Hayley, can you just try again? See if you can. Unfortunately, we can't hear either Hayley or Gareth.
Can you hear me, John?
Yeah, Simon, do you want to?
Perhaps I'll try.
You go for it. You go for it. Yeah.
I'll try my best to fill the gap. I caught the end of my recorded presentation. I think I should perhaps apologise. It sounded a bit stilted, so apologies for that. But yeah, I mean, this is a challenge, isn't it? You know, we know that the precautionary measures that you guys are having to work under will be with us for some while to come, and that is going to have an impact on the numbers of patients that you're able to treat through normal capacity. I'd love to be able to offer a comment on when those restrictions might be limited, but I don't think that I can, unfortunately. You know, we've got to continue to provide a safe service, and clearly what we are expecting health boards to do is find ways to maximise the amount of patients that can be treated by looking at how they can create appropriate separation, green and red pathways. When air exchange is a challenge in a number of the units, so it's a very important point and a very fair point, well made. And I'm afraid I can't offer you an easy or quick answer to that. I suspect Gareth and Hayley might both have said pretty much the same thing. They might want to nod just to check whether they're agreeing with me. So it is a real challenge, but I think it's one we're going to have to find a way of working with for the foreseeable future, I'm afraid.
I think it's an important one. We look to recalibrate and continue to calculate our demand and capacity activity, because we've got new rules now that we didn't have before. So it's not just coping with a backlog of patients coming through, but certainly air exchange wasn't really part of our consideration, particularly for aerosol generating upper GI endoscopy and bronchoscopy. So even when we get back to some of the perhaps distancing rules being relaxed or going back to normal, as it were, we're still going to have to think about how we manage with the those aspects, which it's likely that endoscopies, air exchange will be thought of much more like main theatres, for example, where that has always been a very big consideration. And we're aware that some of our units have got are not able to get their air exchange systems up to a level where they can very quickly turn around patients. So there are natural gaps, and people are zigzagging between doing one list over two procedure rooms really to do a list of OGD. So it's a big issue.
Yeah, I agree with that, John. I know that Hayley and the team have been talking with all the health boards about any opportunities that there are to improve the air exchange within existing facilities. I think there may be some, but there are, as you and colleagues will know better than I, many of our facilities are rather limited and are not amenable to sort of retrofitting. So I think there is a very important question about how we build towards sustainable endoscopy services. We knew there was a shortfall pre-COVID, and the COVID challenge has really brought that to light. So we've got to both build sustainable services and also deal with a very large backlog of patients. And that's the challenge, as to how to plan to do both. And we need a plan to do both, that it may have some features in common, but looking at new expanded facilities for the longer term will be a really important part of that plan, I feel, and there will be opportunities there to purpose design facilities to cope with things like the air exchange issue that we've just been talking about.
Great, thank you. There's a good point that Jeff's put on the chat there, which I think would link both with Andy's talk and the talks around endoscopy, which is new ways of doing things and how we can share learning. One of the things that's happened with COVID, it has given us a chance to rethink how we do things. For example, I don't think I'd ever in a million years be thinking of chairing a meeting like this on VC 12 months ago. It's still scary now, but it's perhaps less scary than it would, because we spend a lot of our time doing things in the virtual world. Andy, can I ask you whether or not through your setting of your services, do you use a lot of sort of VC technology in patient consulting and what have you? Is that something that's part of your lovely picture, colourful picture that you've showed us?
I mean, I think we have. I mean, we've tried to keep as much face-to-face going as we can, because particularly liver disease patients often physically need to be seen. And I think most people are familiar with doing telephone clinics now, and we've done that, and we've moved into sort of virtual platforms as well. My big concern is we've rushed into doing that without understanding which is the right patient to do that in. Now, obviously, in the first wave, we didn't have a choice, but I think we're at a position now, and this is where I think cohorting of your clinical load is so important to get an understanding to which patient needs to be seen in which part of the service. So for hepatology, that could be specialist nurse, it could be consultant, it might be community, it might be primary care. For IBD, that might be, IBD specialist nurse. And so understanding where these people are in the system and which technology suits them best. Some people will always need to be seen face-to-face or will benefit more from that. So I think having a really good understanding of your clinical workload is so important to actually mapping out which patient should be in the right part of the system and then utilize the technology for those patients. That's my view.
Yeah, great answer, Simon. I guess that the whole sort of digital revolution is that we are playing a bit of catch up with the NHS, aren't we, with our digital kit? But presumably that's a very big part of NHS Wales's thinking going forward, because we can see the benefit with some of our patients with consulting this way. I think it suits the patients pretty well because they don't have to drive to hospital and find a car parking space and wait for ages and the waiting room. So I just wondered how the digital sort of side of things was part of NHS Wales's thoughts going forward.
Yeah, it's very much part of the thinking, John. But I think just to stress the point that Andy made, I think that works for some patients,
yes,
but not all. I think what we saw in the first phase of the COVID response was the ability to make decisions very, very rapidly, to change pathways, to put different responses in place. And I think we've got an opportunity now to build on those, and that might mean scaling some of them back to bring in some more patients face to face, but it does allow us to look at digital solutions, different pathways, different roles for colleagues working within the service. So it's an opportunity to become very prudent in the way in which we approach health and care in Wales. So I think there's huge opportunities that we can build on from what worked well during the early stages of the COVID response. I'm sure that there will be some elements that will say, well, that might have been appropriate for that time, but that particular response should not be a feature of our work going forward. But I saw lots and lots of innovation driven by you and your colleagues, just getting things done. So many things that would previously become mired in excessive bureaucracy happened quickly. Now, I mean, the right amount of bureaucracy is necessary for good governance, but we've also got a huge challenge as we go into the recovery phase. And I suspect that we'll look back on the first wave of COVID and think in a way that was relatively straightforward, because the response was create capacity as quickly as you possibly can. I think now we've got a very complex situation to deal with a huge backlog of harm built up in our system across not just the hospital part of the NHS, but primary care, the impact on communities. So I think the recovery task is going to be very, very complex, and we're going to need to see continued innovation and change, of which digital is a part, not the whole, but an important part.
Brilliant. Just a minute before we need to go to the break, but just a couple of good comments that have been put up here with perhaps if Andy or Simon. I don't think Gareth and Hayley, we can hear you still. Can we say something? No, unfortunately we can't. So the three of us will chip in if we've got any comments. So one comment from Fires, which is a really good thing about electronic endoscopy requests. We're very much on that with the National Endoscopy Programme. We realise greatly the value of doing that for speeding patient pathways up, for governance, etc. So that's really very much part of our thinking, Fires, thank you. And it helps us with vetting and feedback. We know health boards have got different systems and different ways of doing it. We think it would be good to have an NEP based approved all Wales kind of approach towards that. We think that'll be really helpful. And then Barney's made a good point here. Again, this goes along very much with what Andy and Simon have said, which is, should we really be offering patients a choice of which they want to consult? So perhaps we may have a horrible word, I have to use it, blended approach in the future between face-to-face consulting and video consulting. So there may be some of our clinics, some of our chronic disease management clinics can work in a distant way. But there are some patients I know, and your hepatology patients, they're probably quite a difficult group sometimes to actually, because you do need to sort of examine them and look at them, and perhaps more so with liver patients than luminal patients, really, in terms of being able to actually physically see them at sometimes. But Barney's point is, should we be giving the patient the choice whether they're going to want to see us via VC or via face-to-face in the future? Quick thoughts about that, either of you?
Yeah, 100%. I mean, I think, sometimes patients would express a choice to be done over the telephone, but it might still be better to see them face to face. But that allows you to engage in a conversation and a dialogue about the best way forward. But I think, we just do need to understand who is best suited to what. And obviously, if you're traveling further distances, one very brief point I want to make, we talk about sharing information and best practice. Should we start to share our resource? That's our workforce, our physical environment. If you've got challenges in certain areas and you can't recruit in others, we should be cross-supporting far, far better. And I know ICU have started to do these sort of shared job plans between different health boards. We need to be far more creative about doing that sort of thing, so we can then map out this not just on a regional health board basis, but on the whole of Wales, and how do we support more rural areas. And you can do that virtually as well. So I think we need to be a lot more creative, and I think we can be.
Brilliant.
Yeah, I'd absolutely agree with Andrew's points there. The consultation has to work from the clinical perspective and the individual patient's perspective. There will be some people who presumably may not be at all comfortable with the thought of a clinical conversation over the internet. My 90-year-old mum may be one of them, for example, or she might surprise me and turn out not to be. And I absolutely agree with that question about sharing resources. We built our system as a population-focused healthcare system, and we need to make sure that in the right geographical groupings, we're making the right choices to provide equitable services for the population. So I absolutely agree with that, Andrew, and that's definitely a theme that the endoscopy program board has been picking up. There are huge opportunities here to change and build some positives.
Brilliant. So I'm going to draw the session to a close. Can I thank all the speakers, all four of you who are on the screen here. I'm sorry the gremlins have got to Gareth and Hayley's systems, so they couldn't join us. They were on sort of permanent mute, to apologise. But thank you for all four of you for contributing towards this afternoon's session. It's been great. And thank you, Andy and Simon, for being able to answer and contributing towards the chat. We go now to some videos to be played from our sponsors. As always, Wage is very grateful for the sponsorship we receive. It enables us to be able to carry out these sorts of meetings and to support our wider activity. So we have 3 videos to be played now, and then we'll come back with the second session afterwards. Thanks very much.